Okay. Yeah, so the first question for today is that there is a 6-year-old boy. He is brought to the office due to frequent nighttime awakenings several times a week over the past month. Again, frequent crying, appearing frightened, and saying that he became lost in a crowd and couldn't find his parents. Although he's comforted, he refuses to return to his room. All He eventually falls back to sleep. The boy is about to start first grade. He is healthy. He has achieved all developmental milestones. Examination shows no abnormalities. What sleep stage is associated with the frightening episode within the child? What do you think the answer is?
C.
C?
Yes.
Anybody else?
Yeah, this is C.
Why?
These are the nightmares, the rapid eye movement sleep.
Okay. So we
Yeah.
see that this is C. Yes. So we know that in the REM sleep and rapid eye movement sleep, it occurs more frequently in the final third of the night when the REM period becomes longer. Again, why do we know that it's REM? Because the boy's recurrent awakenings were associated with dream content and ability to be comforted are characterized by nightmares. Again, nightmares are very frequently found in REM sleep. Again, how do you differentiate REM and non-REM sleep? How?
With EEG.
It
Right.
involves the REM sleep. It involves the voluntary muscle atonia, whereas
Okay,
the non-REM is not associated with this.
all right.
In
Yeah.
REM
Yes.
sleep disorder, we don't tend to remember the events, but in non REM, we do.
Okay. All right. Yeah. So when we talked about the REM sleep, again, it's very important for you to remember differentiation between REM, non-REM. How many stages are there? There are 3 stages. Be familiarized with that. REM sleep, again, it has voluntary muscle paralysis, as she mentioned, and it occurs during the final stages of the night. Nightmares are a common occurrence within the REM sleep, whereas the non-REM, you do not have a voluntary muscle paralysis, all right, and it can be differentiated on the basis of sleep terrors, all right. Sleep terrors usually occur in non-REM, and nightmares occur within the REM. So, how do you differentiate nightmares between sleep terrors? What's the differentiation?
Sleep terrors are not remembered, whereas nightmares are remembered there afterwards.
Exactly. Even the word states that nightmare, you can recall those sequence of events, but in sleep terrors, you cannot do that. All right. We have a next question for today. So we see that the temperature is 36.7, or our blood pressure is a little high. The patient is somnolent, but he's arousable to voice. Pupils are bilaterally equally reactive to light. Again, bilateral upper and lower extremity muscle strength, DTR, pain sensation are normal. Everything else is normal. So what's happening? A 68-year-old man brought to the ED by his daughter due to change in altered mental status. Over the past 2 days, the patient has reported seeing strangers. All right, seeing strangers or around the house only when he and his daughter were home. He was intermittently confused, difficult to rouse, distractible, and he has no other psychiatric symptoms. These neurological symptoms have flared up since he moved in with her 2 weeks ago. What's happening? He's
I think
68.
he's having this, confusion, difficult to arouse, and he's having some, some allergic or seasonal thing, and maybe he's using some antihistamine, and it reduce this because it's only 2 days for this problem happening. And here they are specifically mentioning that
Yeah.
he's having seasonal allergies, which the doctor say he flared up since he moved with here two
Yeah.
weeks ago.
Mm-hmm. And patient's condition is consistent with delirium, like
Okay.
which has the waxing and the waning course. Yeah, it's due to the most probably due to the medication side effect. Yeah.
Okay. Let us see that if you're right or if you're right. Yeah, so again, we need to differentiate delirium with dementia. Delirium is waxing and waning. It usually occurs due to medication, or a patient may also be delirious. So, in elderly patients, the most common cause of delirium is number one, UTIs or any sort of infection. All right,
Mm-hmm.
infection is a very important source of deliriousness in elderly patients, especially in 70 to 80-year-old patients. UTI is again the common cause. The second thing is that it can be because of a lot of medications. Because as you might have studied the Beers criteria, you might have seen that there are certain medications that you generally avoid in elderly patients, such as antihistamines, anticholinergics, benzodiazepines, high dose opioids. So you avoid all of them because they kind of caused a state of deliriousness within the patient. All right, again, it cannot be any sort of, it cannot be frontotemporal, because again, frontotemporal usually involves less uh, adult of a man. They usually involve younger people. Again,
Yeah.
frontotemporal, you will see personality changes first. So it doesn't paint the picture of that. It can also be, again, people say that, oh, it might be Parkinsonism with visual hallucinations. They're very characteristic of dementia with Lewy bodies. But again, the thing is, we do not see any Parkinsonism signs, so it cannot be that as well. It could be a brief psychotic disorder, but again, the patient does not present with any personality changes. All right, so you kind of exclude them out from the picture. And again, hypothyroidism can cause, but again, they did not give us any sort of medical history. The patient was told that the patient does not have any chronic medical history, so it might have been medication. Again, try to kind of go through the question stem and eliminate out the answers. All right, we have a next question. The mother says, although her eyes are open, she appears to be in a daze and does not respond to me. I guide her back to bed and she goes to sleep, but I worry that she could get hurt or fall down the stairs if I'm not there. The girl has no recollection of the events. What stage of EEG is the sleep stage associated with? So, what is she having?
Somnambulism.
Okay, anybody else? What is she having?
She's walking,
Sleepwalking.
sleepwalking.
Sleepwalking. Yeah, very
Mhm.
good. So in sleepwalking, what do you see? What type of waves do you see?
I think it's deep sleep,
REM,
theta waves, right? And three.
non-REM sleep, I think.
It's a
Yeah.
non-REM sleep
No.
disorder.
Mm-hmm.
So we agree with C.
Yeah, delta waves. See.
Again,
So
these sleep patterns are very high yield for you to remember. They get tested in the questions again and again. Non-REM stage, N1, N2, N3, REM. Again, you need to differentiate between what's a sleep stutter, what is, sleepwalking, what is a nightmare. Be able to differentiate amongst them. Very high yield for you to remember. So if you kind of go through them, you will see that REM one, it's like the wakefulness sleep transition. You're easy to wake. Non-REM two, they have sleep spindles and K complexes. Again, that comprises most of the sleep. Non-REM three is prominent first half of the night. You're difficult to wake. Again, patients sleepwalk or night terrors occur during this stage where you have delta waves. REM, you see EEG resembles wakefulness. You have sawtooth waves as well. Again, be very familiar with each and everything. It's very high yield for you to remember. Okay. All right. So we're not gonna do this. Okay, I'm gonna go random so that we can have an idea. All right. Okay. So what's happening? A 22-year-old man undergoing surgical repair of the inguinal hernia. All right, anesthesia is induced and an endotracheal tube is placed. He then develops severe spasm of the masseter muscle and there is decrease, and there is a dramatic increase in expired carbon dioxide. All right, his core body temperature begins to increase and it's now 102. Which of the following is most likely underlying mechanism leading to elevated body temperature? What's happening?
malignant thermia, hyperthermia.
Malignant hypothermia.
Yeah,
C.
usually having with anesthesia, and it will be having also muscle spasms
Mhm.
Okay,
due to
so
excessive calcium. Yeah, impaired
I
fitness.
think it's C.
Yeah,
Excessive myoplastic calcium accumulation. Yes.
Calcium accumulation.
Ryanodine pathway or something receptor.
okay, so we go with the answer D.
C as in cat.
No, this is E. 0%
I
because
wanted you to at least do some questions wrong as well so that I can explain you as well. You all are doing everything right. All right. Again, very good. Malignant hyperthermia. Again, why is malignant hyperthermia happening? Because of the genetic mutation of the ryanodine receptors. It's triggered by inhalational anesthetics such as succinylcholine. Very important, very high yield for you to remember that it causes spasm, hypercarbia, rhabdomyolysis. Hyperthermia is a late manifestation. Again, you reverse it by dantrolene. So the treatment is also very important. Again, you're familiar. Okay, how do you differentiate? Okay, no, this is not. It was a psychiatry question. I was mixing that up. Okay. Okay, next question. Random.
Dr. Maheen, I have a question. You said something about sawtooth waves. What were you saying? I just missed on to that point.
No, I said that in REM sleep you see sawtooth waves occasionally.
Okay, thank you.
All right. Okay. Next question. 27-year-old woman comes to the office due to almost daily headaches for past 3 months. Patient describes constant dull pressure in her head that is worse at the end of the day. Office manager able to work through the pain. History of seasonal allergies, and her sister has migraine headaches. Which is the diagnosis?
tension headache. This is
Tension headache.
Okay. Why cannot be it migraine without aura?
migraine is unilateral.
It's constant.
And
Yeah.
you can't tolerate it.
Okay.
Pain.
What do you see in cluster headache?
Cluster headache is
Cluster is more
associated with the
in male.
Comes in clusters actually, so it's not one-off.
Ipsilateral ptosis, hydrosis, and hydrosis.
Exactly. So in cluster headache, you also have eye symptoms. All right. You see lacrimation from the eye, again, like kind of like severe pain. So you also have eye symptoms. How do you treat cluster
Autonomous
headache?
symptoms.
Mm-hmm.
How do you treat cluster headaches? What do you give? What's the immediate treatment for cluster
High
headache?
pressure.
Duration
High-
Oxygen and sumatriptan.
100%
and
oxygen.
duration also. It's for the like past 3 months.
100% high pressure oxygen.
So for the
oxygen.
abortive therapy for cluster headache is 100% oxygen, and the kind of like the follow-up therapy, you can give CCBs, you can give triptans, but CCBs are usually preferred. All right, so we know that it's a tension headache. Again, very high yield for you to remember. I told you that in cluster headache, usually you have eye symptoms usually, and you have sort of like a excruciating pain behind the eye. Again, you have facial flushing, nasal congestion, lacrimation. Usually you'll find them in males more. When they're talking about females, what is contraindicated in migraines? What medication is contraindicated in migraines?
Beta blockers. Yeah.
No.
No.
Beta blockers prevents migraines, I think.
I think is it oral contraceptive?
Yeah, very good. Oral contraceptives are an absolute
Yeah.
contraindication in women with migraines. You will not give them OCPs. Again, absolute contraindication. There are two types, absolute and relative. This is an absolute contraindication. All right. You can treat them with, you can also treat migraines with an anticonvulsant, I think called topiramate. And you can also give triptans, beta blockers. You can also give topiramate as well. In tension headaches, acetaminophen. Again, sometimes there's analgesic headache as well as it was asked in the question stem.
Medication overdose headache. Yeah.
Exactly. And sometimes they ask you that as well, that when the patient kind of tapers off of the medication and they start developing a headache, it's because the body has become used to a certain medication. And when it's pulled off, then the body is reacting. It's kind of like headache withdrawal. All right. And it's very high yield for you to remember as well. Okay. Then we come to the next question. Again, whatever easy questions are, I'm going to take them off. I want you to answer difficult questions. All right. Yeah. What's this? Okay. What is this measuring of PA carbon dioxide called? What's this? How do you measure it? What's the process called?
This is, I think this is BaCO2.
ABG?
No.
ABG.
Arterial blood gas analysis.
Arterial blood gases.
Mm-hmm. Anybody
And,
else?
and
Is it induced hyperventilation to reduced ICP?
Capnograph?
Okay, how else do you measure carbon dioxide? What's the non-invasive method? So ABG is the invasive method, right? Because you're inserting a needle. What's a non-invasive method of measuring carbon dioxide? What's it called? So it's called
Isn't
it's
it?
called capnography.
capnography.
So what do you do is that
Capnography, yes.
the non-invasive measurement of the partial pressure of carbon dioxide in exhaled breath. So that is expresses carbon dioxide, and then you can kind of measure that level of carbon dioxide. That's called as capnography. It's usually an important thing they will ask you in terms of ventilator questions. Capnography. So yeah, are you saying something? No? Okay. So again, a 19-year-old man brought to the ED after sustaining a traumatic brain injury due to motor vehicle collision. On arrival, the patient is comatose, Glasgow coma scale of 3. You don't have to memorize this, so it's not important. His blood pressure is okay. Pulse is a little erratic. Pupils are myotic. Ecchymosis is present behind the ear. Rapid sequence intubation is performed. The patient is mechanically ventilated. Non-contrast CD demonstrates bifrontal contusions and a basilar skull fracture. 1 day later, repeat head CT scans reveals diffuse cerebral edema. Which of the following is most likely effect of the intervention? What do you think the answer is?
What is the intervention?
Increase
I'm
cerebral
thinking
vascular
D
resistance.
because I think that PCO2 causes vasoconstriction in the lungs and dilation in other organs. I don't know, I might be wrong, but I'm looking at option D.
Yes, I think D is correct because of
Yes.
MIP, the formula of MIP.
So we all agree with D?
Yeah,
Yes.
increase cerebral vascular resistance, yes.
Exactly. So again, the auto regulation of carbon dioxide is really important. It's very high yield for you to remember that. Again, so whenever there is a drop in PO carbon dioxide due to hyperventilation causes vasoconstriction, you can kind of remember it like an example. You go to the principal's office and you're hyperventilating in anxiety and you pass out. How did you pass out? Because of this, that hyperventilation caused a drop in PO CO2, and that is why vasoconstriction happened and you kind of lose consciousness. Again, it's a very easy concept to memorize it. It's a potent vasodilator of the cerebral vasculature. Again, tachypnea, if you're hyperventilating, it will cause cerebral vasoconstriction, and once you're having vasoconstriction, there will be lesser amount of blood going to your brain and you pass out in general. All right. Next question. Okay. 28-year-old woman. She is autoimmune. She is found to have severe hyperglycemia, high anion gap metabolic acidosis. Okay, a classic picture of ketoacidosis. All right. While being evaluated in the ET, the patient develops involuntary rhythmic jerking of her right upper extremity that lasts for a minute. All right. She remains fully alert. The patient has never had similar symptoms in the past. Physical examination shows no weakness. Which of the following is the most likely diagnosis? What is happening?
Seizuring, it's tonic-clonic seizure.
Why is she having seizures?
because of hypoglycemia.
Maybe electrolyte imbalance.
Ketoacidosis.
What else?
Diabetic ketoacidosis.
Okay. So we all agree with the answer D or B.
D.
D.
B. It's focal.
B, Bob.
Focal onset seizure. Yes, focal.
Again, very high yield to you to remember the difference in seizure types. For example, this is a tonic-clonic. Again, you're going to be having rhythmic jerking. They ask tonic-clonic, absence, sometimes myoclonic. They do not ask atonic. So it's okay if you kind of skip that. Again, medication, you give levetiracetam, and you give valproic acid. For absence, you give ethosuximide. Again, remember what they do. So ethosuximide is a calcium channel something. So remember that. All right. And you also give valproic acid. And one more thing. What's that? You also give in mood disorders. So whenever you have sometimes mood disorders or even bipolar disorders, and if you cannot give lithium to the patient because of if the patient has having thyroid issues or kidney problems, so you give valproic acid in terms of the bipolar disorder. You wouldn't be giving lithium. You will give valproic acid. Again, very high yield for you to remember. In any bipolar disorder patient, go through that if they're having any thyroid problems or kidney problems, because then it's contraindicated. All right. Okay. So absence, ethosuximide, again, very high yield for you to remember. These anti-epileptic drugs are very high yield for you to remember. Remember the side effects. The main, for example, carbamazepine causes agranulocytosis. What does gabapentin do? I think it causes some nerve damage. I'm not sure. Just check it out. Phenytonin, I think it causes something to the babies. What does it cause? I forgot. Causes something to the babies. Anyone? What does it cause to the babies? Fetal hydatonin syndrome.
I think
Fetal
miracle
hydatonin syndrome.
defects
I
too.
remember it now. Yeah. So remember the high yield adverse effects. And yeah, so we know that the patient was having high GAP metabolic acidosis, kind of like the patient was diabetes, and as a result, the patient developed diabetic ketoacidosis. The patient is having seizures because of impaired metabolic um, arrangements, and the patient started having seizures. They will be focal onset because only one part of the extremity is getting involved. Again, very high yield for you to remember. Okay, where do you see post-ictal state?
And epilepsy.
Tonic-clonic seizure. Generalized tonic-clonic seizure.
And
After trauma.
In abscess seizures.
so you also see post-ictal state in focal
Migraine.
seizures as well. So you see them focal or in generalized tonic-clonic seizures. They both will be having kind of like a post-ictal state. Okay, so we come to the next question. Okay, so 72-year-old man, poor sleep. Okay. He said that I used to sleep okay, but I cannot sleep now. I'm probably getting only about 6 to 7 hours of sleep total. The patient typically falls asleep watching television at 10 p.m. Again, sometimes bathroom. All right. He likes to do crosswords, play golf in the morning. He occasionally takes 30 minutes nap in the afternoon. He snores softly. Again, everything is normal. So it's normal. So what's happening?
Age-related.
Again, how will you differentiate? What will happen in a major depressive disorder? What will happen in MDD?
In that he will
Weeping
other
spells,
things.
and he would be down.
That major
Or more-
depressive disorder he will have
Major
other
depressive disorder includes
interest
sadness and
in
decreased appetite and suicidal behavior like these.
Suicidal ideation.
Exactly. So you will have feeling of worthlessness, anhedonia, your appetite will be reduced. Again, remember that depressive patients, they are suicidal, but they will never act on suicide. All right. So that's the one thing that, depressive patients have thoughts of suicide. They have thoughts, but they have problem in acting on it. All right. And they feel that they're too scared to act on those thoughts as well. Again, it's a common distractor. Again, depression symptoms, if they're more than 2 weeks, it's classified as a major depressive disorder. If it's lesser than 2 weeks, then what is it classified as?
Brief psychotic disorder. Less than 2 weeks.
Okay. Yeah. So how do you differentiate insomnia? So insomnia, it's a characteristic of having, sleeplessness every single day. And they also feel agitation. They feel agitated throughout the day because they cannot be able to sleep in the night. Again, obstructive sleep apnea, you look for three things. First, you will look for obesity, you will look for hypertension because those patients are hypertensive as well. And the third thing you will look for if they're snoring loudly. All right. So three things for OSA. Again, it cannot be that as well. What do you mean by adjustment disorder?
Like if he had lost his job in the near few months, or he had something like that, which was disturbing him constantly.
Yeah, so there is a time frame. If it is greater than 2 to 3 months, then adjustment disorder will be classified as what?
I don't know.
General anxiety disorder or what?
General. Post-traumatic? I think post-traumatic.
No, PTSD will be no. Greater than 2 months, if the adjustment disorder does not stop, what will it develop? What will you develop?
Depression.
Depression.
It's present at first aid. Go through first aid, all right. Go through the psychiatry portion of first aid.
I
But
think
no,
ADHD.
it's your homework.
Dependent.
Homework. I want to know it tomorrow. Go through adjustment disorder and see that what is it called if it exceeds 2 months. What do you call it? All right. Okay. So again, adjustment disorder usually occurs. For example, if you you send your child to a boarding school and the child is very sad and she feels gloomy. She does not want to do homework just because she misses her parents. That's adjustment disorder. If it is within 2 months, if it exceeds more than 2 months, then you need to find out what is it called. I'll ask you tomorrow. All right.
I think, Dr. Maheen, adjustment disorder usually happen in divorce or illness, divorce instances.
No, I'm sorry.
Generalized anxiety disorder.
Yeah, I said that.
Generalized anxiety.
But I want you guys to go and read it.
Oh, okay. What could be the major depressive?
I already said that. Okay. So yeah, again, be familiar with each and everything. It's very normal in old age people that their REM cycle gets a little bit disturbed, and that is why they wake up a lot of times in the night. I slept with my grandmother for a very long time, and she used to go to the bathroom the entire night. I don't know if everybody's grandmother does it, or mine used to do it, and I used to get a lot lot frustrated because my sleep would then become compromised. So it's very habitual for older people to kind of wake up a lot of times in the middle of night. It can be given as a distractor for having a UTI or any sort of urinary incontinence, but it's usually not a urinary incontinence in most older people. They just feel like they have to go to the bathroom. All right. Okay, then we come to the next question. I'm searching for a difficult one because I don't want you guys to. Yeah, okay. I found it. Yeah. On physical examination, he appears restless and paces in the room. There is mild conjunctival injection and meiosis. 34-year-old man, ED, severe headache, throbbing pain around his right eye that awakened him. Over the past week, several symptoms spontaneously resolved. No other medications. Smokes a pack of cigarettes. What's happening?
Cluster headache.
Cluster headache.
Cluster headache.
Cluster.
Cluster?
Yes, the headache. Yeah.
You sure? Why cannot be it any withdrawal?
It's headache around
Throbbing
the
headache,
eye,
eye
throbbing pain
symptoms,
around this eye,
throbbing pain ahead. Yeah.
male.
Conjunctival injections and meiosis of the right eye. The autonomic problems are also there.
History of
Uh,
similar episodes and
the
autonomic symptoms.
Yes, the restlessness and the conjunctival injection is you and meiosis of the right eye. These are all characteristics of cluster headache.
You
And
know,
also
if I would have, put one more distractor, I would have put in as marijuana withdrawal. Because in marijuana withdrawal, again, they have the same picture. If you do not, if people or students, boys especially, they consume a lot of marijuana, and when they leave it, they have a throbbing pain in their eyes as well. They have conjunctival injection as well, and you will feel them that they're more restless, they're agitated. So if I would have, I had that, I would have put a distractor of marijuana withdrawal as well. But it's not mentioned, it's very obvious what it is. So it's cluster headache. Let us see if you were right. Yeah, we were right. Again, it was cluster headache.
So,
What?
Dr. Maheen, how would you then differentiate it with cluster headache and the marijuana withdrawal you were just talking about?
Because of this, you won't see meiosis and withdrawal.
Okay. Thank you.
All right, next question. All right, let me see. Any difficult questions? Are they? Yeah, what's this? Is it easy? I see this is bitemporal. Are they asking? No, it's easy. Okay, I want difficult questions. Okay, what's this? What's happening? What's this?
This is infarction. Infarction.
Subdural hematoma.
No,
Subdural
no,
hematoma.
this is
Hematoma, subdural.
This is hematoma
Subdural.
And
subdural.
subdural hematoma and shifting of midline.
Okay, subdural.
And the crescent moon.
Yeah, we see that. All right. Okay, so let us see. 78-year-old female, recent onset difficulty walking, Parkinsonism history, blood pressure very high, few falls. This is a classic case I told you guys yesterday. If you guys remember that I told you guys that they will ask you that there is this very old female and she's adult, she has hypertensive history, difficulty walking, and they will come and say that, oh, I just feel that I'm dizzy, I'm groggy, and my head is clogged. And they will, they will say that they have altered mental status, they will have difficulty performing tasks, and they would be fine. And when you ask them how are you, and they'll go like, I'm fine. And when you get a CAT scan, and you will see that there's something wrong that's there. So again, it's very advisable that you always go for a CAT scan in elderly patient who's having, altered mental status. All right, you do
You do
CAT
the
scan,
blood test. Does it also
do
come in?
normal workup, very important. All right, so what do you think the answer is?
Got bridging veins.
Bridging
Rupture
veins.
of bridging veins. B.
Again, very easy. We discussed the concept already. It's very easy. Where are difficult questions? Okay, what is this? 1-month-old full-term boy brought to the ED by his mother due to a difficulty awakening from the sleep. All right. The mother says that the infant was momentarily left alone this morning in the roll of a bed. Since then, he has been sleepy and less active. Physical examination, blah, blah, blah. Bilateral retinal hemorrhages. What does that suggest?
Child abuse,
Ab-
abusive
Child
head trauma.
abuse,
shaking baby syndrome.
taken baby syndrome.
And also a 1-month-old baby rolling. That's not right.
Mm-hmm. So it's why cannot be unintentional head injury?
Unintentional because of the bilateral retinal hemorrhage. So if it's unintentional, the baby will not get bilateral retinal hemorrhage.
Okay. Well, let's see if it's abusive head trauma. All right. Again, very high yield for you to remember shaken baby syndrome. Whenever you have child abuse cases, the first step on any USMLE is to call for Child Protective Services. You immediately call for CPS. And the other thing is you also order a skeletal survey of the child. You see that there are many broken ribs. See these posterior rib fractures, right? So that is why you order a skeletal survey of patients who are suspected of child abuse. Okay. And so go for a skeletal survey, it will reveal that. Go for a CAT scan, it will reveal bilateral retinal hemorrhages, and there are again signs of child abuse, and you rupture the bridging cortical veins in that. Again, see posterior rib fractures. That is why you go for a skeletal survey. And second thing, you call for Child Protective Services. A very high deal for you to know. All right. Next question. Okay, 35-year-old woman comes to the ED for severe headaches and vomiting. The patient has had intermittent headaches, but her symptoms worsen. Papilledema, dry skin, hepatomegaly. What is this condition called? Come on, guys, very easy.
Vitamin A toxicity.
Okay. Eccentric dietary habits. All right, patient's condition. What do you think is happening? Vitamin A toxicity?
Yeah.
Yes.
Yep.
Very easy. Again, vitamin A will cause. So vitamin A toxicity, first, it can cause benign intracranial hypertension. Again, you will see headache, vomiting, papilledema, dry skin. Again, if you consume a lot of egg, there is also this thing. What deficiency you would develop if you eat a lot of egg white?
B7,
Vitamin B.
biotin.
Biotin, very good. Biotin deficiency. Okay, then we come to the last question for today. All right, 24-year-old man, daytime sleepiness. All right, the patient is a college student whose symptoms started around age 12, and he began needing more sleep than his peers to feel refreshed. 2 years ago, he started having daily episodes of sudden weakness, consistently triggered by laughter or crying. I think I told you guys this. Nightly dreams, often real, engaged. I told you guys this. What's the answer? Excessive daytime sleepiness.
Narcolepsy.
Narcolepsy.
D.
I told
No.
you guys to go for it. And what treatment do we give?
Dantrolene.
No.
Melatonin. Melatonin.
Modafinil.
Okay.
All right. So it's also mentioned that the modafinil, it increases orexin A and B levels. I think I told you guys that when I was talking about narcolepsy. Again, recurrent lapses into the sleep. You will have cataplexy, brief loss of muscle tone that's usually incited by any sort of strong emotion. You will see, I told you guys that you have low levels of hypocretin 1. Not only orexin 1 is low, but also orexin 2. It's also known as orexin. Hypocretin 1 is known as orexin 1, and hypocretin 2 is known as orexin 2. So those levels are down in narcolepsy, and that is why you kind of get the condition. You give modafinil as a treatment. So what modafinil does is basically it increases the levels of orexin 1 and orexin 2, right? Or orexin A or orexin B, vice versa. All right, we are done for today, guys. I have an important announcement to make. Dr. Ahmad won't be joining us today. I think he's a little busy. So you guys will be doing your UWORLD or whatever on Discord. All right. So if you guys have any questions,
Yeah, you
you can
asked
ask
us
me.
yesterday about
I'll be
something
reading.
to read about it.
Yeah, what did you read about it? I forgot. What did I
You
give
asked us
you?
about the dopamine receptors and these things. Yeah.
Yeah, very good. So anybody up for it? What are the primary messengers? What are the secondary messengers? Anybody?
Yeah, we read it. It's
Yes,
heavy.
Dr. Chip. Continue.
You
Continue.
You can ask and we can help each other to answer. We try to
Help
read
each
it.
other. But USMLE step one exam is not a help each other exam, right? It's like an independent exam. So I want each and of you to be independent while solving questions. So what are the primary messengers? What are the secondary messengers? What is inositol triphosphate? What do you mean by CAMP? What is CGMP? What are some of the hormones that are regulated by them? Come on, guys. Anybody?
Yeah, we read, but
You will reread again. So you have two tasks for tomorrow. First, go through this. The second, I told you guys to go through adjustment disorder and read about it, and what is it called if it's like greater than 2 months, and also read about that condition as well. Go through the timelines. Those timelines are very important in psychiatry. The weeks, the days, they're very high yield in psychiatry because diagnosis changes based on the time. So it's very high yield for that. Go through the timelines, go through adjustment disorder, go through what it becomes greater than 2 months, go through the secondary messengers, primary. I will be asking you tomorrow what hormone is regulated by what. All right. They throw you in USMLE step one. Unfortunately, USMLE step one is a very root memorization based exam. Thank God I'm done with it. I don't have to take that exam ever again. But unfortunately there's no other way to kind of surpass it. You have to do it and buckle hard, guys. You guys are very close to your exam deadlines. There's very short amount of time left, so just work twice as hard now. Okay.
thank you. Yep.
All right. Okay. So I'm ending the session. You guys can log into Discord and start practicing questions over there. Dr. Ahmad will see you tomorrow. I'll see you tomorrow as well. Until then, take care of yourselves and good participation, guys. I really like it, especially on the group chat as well. I'm seeing that. So good participation, guys. Keep it up. Okay. I'll see you tomorrow. Bye bye.
Thank you, Dr.
Thank
Maheen.
you so much.
Thank you so much. Bye.
Thank you.